All right, so yeah, let's get going. So good morning, everyone. Welcome, bienvenidos. For those of you who want to continue in English, please stay put. And las personas que deseen escuchar la versión en español, por favor, elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias. So good morning to all of our live attendees today. We are thrilled you're here to engage in this exciting webinar, The What and Why of Culturally Responsive Integrated Care. I'm Dr. Tiffany O'Shaughnessy, and I'm one of the hosts of our webinar today. I use she, her pronouns, and I'm a white, cisgender woman in my early 40s with an undercut buzzed hair on my left side and chin-length reddish hair, brown hair on my right. I'm wearing a black top, and my background is a mountain tapestry scene. I'm a faculty member and the MFT program coordinator in the Department of Counseling here at SF State. I'm also one of the co-investigators for this project. I'm working alongside the project's primary investigator, Dr. Julie Cronister, who's the coordinator of our clinical mental health counseling program, and my co-investigator, Dr. Molly Streer, who's the coordinator of our school counseling program. I would also like to thank our graduate assistant today, Lennon Fanning, who's working hard to stay on top of technical issues in the chat boxes for us all today. I'd also like to take a moment to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and the waters of many indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We're committed to ensuring this webinar is accessible to our audiences. Closed captioning is available in the closed captioning option at the bottom on your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, and so we appreciate your comments, feedback, and support. This is our fourth webinar of the year, sponsored by our Equity and Justice Focused Integrated Behavioral Health Counselor Training Project, which is fully funded by the Department of Health and Human Services, Health Resources, and Services Administration as part of an award totaling $1.9 million. A couple of additional things before we begin. If you're one of our HRSA stipend recipients or are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat or sign in and for the sign in and evaluation links. As a reminder, this is a live recorded Zoom webinar. Therefore, the audience is not visible and you can't turn on your audio or video. The chat function, though, is available for comments, sharing of resources, supportive emojis, engaging with us throughout this webinar. If you have a specific question that you want to ask, please post that question in the Q&A function of Zoom. We'll save 10 to 15 minutes at the end of the webinar for a Q&A. So please post your questions as they emerge, and the presenter will answer questions at the end. If we can't get to all the questions, we're going to share our email so you can contact the presenter or us directly. And with that, it is my great pleasure to introduce today's presenter, Erica Gomes. Erica Gomes is a licensed clinical social worker that's been working in the nonprofit sector, providing clinical social work services for the past 20 years. She started her career as a domestic violence counselor and has worked primarily in medical settings, providing services to a variety of populations, including children, youth and families, pregnant and postpartum women, and individuals living with HIV or AIDS. She's worked in a community health center in San Francisco, providing bilingual English-Spanish clinical services, developing and implementing their integrated behavioral health model. She also provided outpatient sliding scale psychotherapy services, mental health evaluation for asylum cases, and has worked internationally, providing social services in Central America. She's a MINT certified trainer, a member of the Motivational Interviewing Network of Trainers, and an exam writer for the Association of Social Work Board's clinical licensing exam, and has contributed to research related to culturally adapted best practices and group CBT interventions for unaccompanied minors. She is a lead integrated behavioral health supervisor at La Clínica, where she supervises a team of clinical social workers who provide integrated services at several medical and school-based clinics throughout Alameda, Solano, and Contra Costa counties. She previously served as a practicum consultant and lecturer at UC Berkeley, and I will now hand it over to Erica, who's going to take us through the what and why of culturally responsive integrated care. Thank you again, Erica.
Thank you. It is a huge pleasure and honor for me to be here with you all this morning, and especially because I get to talk about something that I feel very passionate about, very excited about, which is integrated care, and particularly culturally responsive integrated care. And a couple of things I just want to kind of say the lens that the particular lens I'm speaking from is of someone who's worked in integrated care for about 15 years or so, but definitely always and mostly embedded in our primary care clinics. And my particular lens that I'm speaking from is working within clinics in the East Bay. So integrated care within La Clinica, in Alameda, Contra Costa, and Solano counties, and also working in school-based health centers. And so I think that's important just to kind of say, like, I'm going to talk about integration and the integration I've seen in practice, but there's many different applications of integration across many different sites in many different counties. And so some of this might be familiar to some, and some might look a little different than the integration you maybe have heard about. So just kind of wanted to start from there. And secondly, I also want to just say that I'm here because of learning from so many people. I feel like integrated in care is definitely one of these emergent practices that, it's still very new, very fresh, and it's evolving every single day. When I started this work, there just wasn't a lot of research out there. And so much of what we did in building programs was to talk to other people. So really collaborative creation of these programs alongside other folks, alongside other community-based health centers who are doing this work along with us. And most importantly, learning from our patients and just seeing, what our patients really most needed and wanted, and evolving our programs to match that. So just wanted to start with those two things to ground us. So what are our learning objectives today? So we're definitely going to talk a little bit about what is integrated behavioral health in primary care settings. We'll definitely talk about screening tools because those are definitely foundational in our practice of integrated care. And then thirdly, really thinking about culturally responsive applications and integration. So talking a little bit about modalities and approaches utilized in integrated care settings. And I'm going to do a little bit of zoom out, zoom in. And so zoom out and talk about integration in general. And in spaces, I'll really try to zoom in and maybe do some sprinkled touches on, cultural adaptations in our practice and how we work within La Clinica. All right, so we'll talk again about the different models of integration, really in zooming into what the team looks like on the ground and what the work looks like on the ground, and then weaving in these client perspectives and cultural considerations. And here, this is really just one definition. There's so many definitions now, which is really exciting about integrated health. So this definition is integrated health is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. This care may address mental health and substance use conditions, health behaviors, including their contribution to chronic mental illnesses, life stresses and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. So this is one definition. As I mentioned, there are many. But what I like about this definition is it really speaks to the fact that we're really trying to center patients and families in our care, and we're really looking to them to direct the care. And it also really emphasizes that it's a team-based approach. You really can't do integrated care alone. It's kind of the antithesis. We work embedded within a team. And it is like that old adage, like we're stronger together. And really that is seen fluidly with integrated care as we're all bringing our expertise to bear into providing the best possible care to our patients. And then just at the bottom, so what are some key principles of integrated care? So again, really looking to the patient and centering them in our care team. Integration really looks at population-based care. So we know in our clinics, we're seeing tons of people. And so we're really looking at trends, what's showing up for our population at this point in time. What are some health disparities that we're seeing amongst our population, and how do we want to address those? So we're really thinking with that big picture mind while we're doing individual interventions. We're really focusing on measurement-based treatment. So again, kind of another little pointing to that, the screening and assessment tools, and really thinking about interrogating, like, how do we know our patients and clients are doing better? How can we measure that in all the different ways? And we do also really focus on evidence-informed treatment. So it's not, it's a nice blend of like being foundational in our research and foundational in evidence, and also where possible being able to apply that to our practice. So that might mean that we're doing certain applications, but we're doing those with the basis of evidence-based, being evidence-based informed. So here's just some statistics just to kind of bring to light, a little bit of the why integration, why is it important? More than 65% of antidepressants are prescribed by primary care physicians, and yet depression screening doesn't happen in a lot of practices still. Only 41% of patients with mental health issues actually receive treatment. I think that statistic can be even higher than that. Between 30 and 50% of patients referred by a primary care provider to outpatient mental health care never actually make it to their first appointment. So that's if it's based off-site, really not successful in folks carrying through with that referral for a variety of reasons. And then compared to routine primary care, enhanced primary care behavioral health services deliver far superior health outcomes for many different conditions. And noting here that conditions meaning medical conditions and behavioral health conditions. So both sides of that do benefit from having an integrated setting. And here's another just kind of more pictorial view of this. So this is looking at a Venn diagram of overlapping between folks with medical conditions and folks with mental health conditions. So the two things that I wanted to point out here is 68% of adults with mental health diagnoses also have chronic medical conditions, and 29% of adults with medical conditions also have significant medical conditions, chronic medical conditions. And that seems like a lot. And also I would argue that those numbers could be even higher if we think about not just folks who have chronic mental health conditions, but also folks who, may from time to time suffer a great loss, right? Or have a traumatic event, or have a huge shift in family structure, right? And those, in those cases, those bubbles can overlap even more. So thinking about lifetime need for behavioral health services, not just for folks who are experiencing chronic mental health issues. And again, why integrate, right? So it's really important to talk about all the barriers to care. Now, I've just listed a few here. I am absolutely sure that many of you can come up with many more barriers to care. But thinking about what gets in the way of folks making it from primary care to behavioral health, robust behavioral health services. There's many factors. The things we see a lot of, particularly in our outer county clinics, so Solana County, Contra Costa County, transportation becomes a huge barrier to care. It's really hard for folks to get all the places they need to get if they live far from, the city center. And so it's really hard not just to come for like one, primary care visit if you need to refill your medications, but then to think about coming back into town, gas being so expensive, to access behavioral health services as well. So that's a huge barrier. Stigma. So this is huge, and we've seen in our practice over and over again. Can be a huge barrier for patients in accessing care. So what does it mean to access behavioral health care? How do we talk about that in our families and in our culture? Like, how is it looked upon? So for some of our patients, it's accessing those services. I'm not crazy. I'm totally fine. I just, had this hard thing happen to me. So there's this, stigma, I think that exists, has existed for many years in many cultures. And so how do we kind of work with that, right? Language, this is a huge piece for many of us. And I think in our world, working with populations that have been largely medically and underserved by the behavioral health system for many years, a huge part of that is just having, language accessibility. So, in our practice, many of our folks are bilingual, which is amazing. But we also, and primarily working with the Latinx population, there's a huge diversity within that population. So some of our patients, Spanish might be their second language, and they primarily speak an indigenous language. So we also struggle with accessing appropriate interpretation services for our patients. So this can also be a big thing. Just the time to access. We work with a lot of folks who are day laborers, and time is money, right? So carving out time, they don't have sick leave, they, don't have those luxuries to be able to take care of their health and wellness. And so that's a huge barrier for folks. Unknown or unfamiliar system, I think this is a huge one. So a lot of times we assume, folks are going to understand why would you want to go to behavioral health? What is the benefit of behavioral health? That might be a system that is just completely unknown to folks. There are many different ways of achieving healing, many different ways of improving wellness. And culturally, there can be many different approaches, and therapy might not even be in the top five. So just thinking about how these systems can be really unfamiliar and incredibly hard to navigate, as we know. So that brings us to the last one, which is access. So, do they have insurance that's going to cover behavioral health services, right? Is there equitable access for the individual that we're trying to get into care? So these are all the barriers that we see. And then kind of tying this together, we think about health equity. I have just really simple definitions here, but health equity meaning all members of the community have fair and just opportunities to be as healthy as possible. And our health disparities, right? These are preventable difficulties in access to care, quality care, or the coverage for care, right? And so I really truly, this is what gets me excited about integrated care, because I really do see integration as a bridge for, getting patients that care that, really can help level out the playing field here. So patient-centered care, engaging, inform, empowering patients and caregivers to participate in care while offering it in a way that's highly accessible and relevant. And so I really see integration at the heart of this. So we're really bringing, connecting those two things together, offering care in a way that's just easy, accessible, and meaningful, right? So this is the quintuple aim. Some of you might be familiar with this. This has evolved over time as well. I think the original version of this came out 2008 or so. And it really just had like three focuses, but basically it's looking at and if we're striving towards something in primary care and we're striving towards bringing like the best possible care to the community, what are we really focusing on? What are our aims, right? So, we had the patient experience at the heart. Looking at population health, as I was talking about before, what are the trends and things we want to keep in mind? We want to reduce costs, overall costs, so less hospitalizations and providing care in a more effective way. And then later on, there were a couple other additions to the aim. So one is really looking at the care team, right? So we had folks doing like really, working at the top of their scope, seeing so many patients, and also started thinking about, well, if we're not supporting the care team and thinking about the wellness of the care team, how can folks really stay in this work for a long period of time, right? So we've got all these committed folks who really want to do this great work. So how do we also take care of our teams? And taking care of our teams in all ways, right? Taking care of our teams, realizing that we need to be talking about burnout prevention. We need to be talking about wellness. We also need to bring some specific skills around trauma-informed care in so that folks are really understanding, why it can be complex to do this work in the way that we do. And then the last piece, which I already spoke to, which is health equity. So how are we looking at health disparities? How are we really interrogating our practice to make sure that, we're not just doing really well with like a certain section of our population, but we're taking a step back and looking at like who's actually not coming into the clinic, right? Or who's coming in, but who might not be getting better. And how can we really, think about an equitable practice for all. So I'm going to go through this one a little quick, but this is just to kind of drive home the point that there are many different models of care, and you might see different applications of integration across sites and across counties. And that has a lot to do with, what the system of care looks like, and also has a lot to do with what I'm aiming to achieve, right, in my patient population. And so these are just some different ways that integration is talked about. So vertical integration really means that you're looking at a specific condition or a specific population within your clinic population. So this might be, oh, we want to target our integration efforts towards our elders in our practice, elders with depression, for example. So a lot of the resources and screening will go to screening certain age groups, and then the clinical support will be working with those age groups on a particular condition, for example. And then on the flip side, there's horizontal integration, which is really working across all populations and all conditions. So we're looking at all of the age groups in the clinic. We're doing screening for everybody. And we're really going to target and tailor our interventions based on a variety of different behavioral health conditions that are surfacing. And then other models, primary care behavioral health model, which is kind of came out of health psychology. This is more the consultation model. So clinicians are embedded in primary care and they're just doing really brief consultations with medical providers throughout the course of their clinic day. Co-location model. So this might be where, you know, there's a primary care clinic and they're bringing in an agency maybe that traditionally does mental health services, and they're there for, you know, maybe a few days a week, and they're working alongside, but they're not necessarily fully integrated. And then I'm just going to talk also about reverse integration. So this is where you might have a specialty behavioral health program in the community, and they might bring in nurse practitioners or medical providers who will provide some medical care on site in those settings. So, and I always like to end up with really, truly what a lot of us are doing is really like a hybrid or a blend type model. And this is really where we look at the population we're working at with, and we kind of decide, you know, what would be the biggest impact on our population. And we might be doing a variety of these things at any one time in our practice. And I think probably many of you are familiar with the continuum of integration, but it's really just looking at, and this is more aspirational. I like having arrows in both directions because it's not that we're looking to like fully move in one direction and in all ways in all of our clinics, but we're really talking about a continuum. And at any one point in time, our clinics might have different programs that are on different parts of this continuum, right? And so moving from really kind of more separate or siloed practices to co-location, then some integration in specific programs, and then kind of a fully integrated care and systems. And so I think it's always a great practice at any moment in time to just kind of think about like, how are we doing with integration, right, in all of our programs. So, and I've seen many times in our practice, you know, we have at 16 different clinics where we have clinicians, 8 of those school-based health centers. And at any one point in time, I think you could place our many clinics of ours at different points of this continuum, and particularly when you have a lens on for certain age groups and conditions. And this is where I always take a little commercial break because I love integration. I could talk about it all day as like the most amazing thing. And I think it's really, and kind of a little bit of the humility here is it is important to remember that IBH is really just a part of the puzzle, right? In the best case scenario, integration is happening in a larger system of care where we have all the other players in place too. So we've got a really robust specialty behavioral health programs that we can refer up to when needed. And we also have a really robust network of care where we can refer people out if they need more frequent treatment. So it's amazing. And we are part of the wellness puzzle. So just in terms of targets, so I always like to, again, talking about the system of care, you know, really orient to where IBH is. And so in most IBH settings, we're really targeting care for folks who are presenting at this moment with mild to moderate symptoms, behavioral health symptoms. And a lot of times integration, clinicians who are working in the integrated model, when we see everyone in primary care. So when we see folks who are presenting with more moderate to severe symptoms, some of our work becomes how do we get folks into that system of care? and navigate that system of care, because that's where we see a lot of drop off too. So that's, kind of what we're aiming for, is that more mild to moderate. And, always to keep in mind that, this is not static, right? So often we're working with folks in primary care who, this month they're presenting with more moderate to severe symptoms. Something really significant happened in their life. They're off their medications or something, some change happened. So they might need to step up to a higher level of care to stabilize. And then once they're doing better and they're more stable, they might be stepped back down to primary care. So thinking about this as a fluid and dynamic movement that happens in the system of care. And this is also kind of in that same vein, we really think about what's called stepped care. So that is saying, like, the best case scenario is we're assessing and reassessing folks to make sure that whatever system of care they're in, whatever level of care they're receiving, is really the appropriate one for them at this point in time, and that we are making a commitment to help move folks, up and down as needed, and really helping navigate through those shifts and changes as needed. Okay, so this is a bit more on how IBH works on the ground. So again, zooming in a little bit, what does it actually look like? So I'll mention a few of our hallmarks here without great detail. So we're, again, looking at mild to moderate presentations. We tend to not talk about like opening cases. So if you're more familiar with specialty behavioral health, you kind of open a case, you have a caseload, but we're more thinking population-wide. And seeing folks, kind of when they need to be seen, how they need to be seen. And so for that higher severity, we're going to support linking up. And then I really like talking about our care as episodic. So we are, we are in people's medical home. So they're always going to be coming to their medical home for, their entire life. And we may have touches with them in an episodic way. So, family's going through a really tough transition. We're going to see them or some members of the family maybe for a period of time. And then we'll kind of fade into the background when they're doing better. But we're still part of that care team. And then when a new need comes up, we'll kind of dip back in and we'll have another episode of care potentially with this individual. We're also, definitely managing a lot of crises. So oftentimes, and particularly with the groups, the communities we work with, medical care is more accessible than emergency care or crisis care. And so they might first go to their medical provider if they're having a crisis, because that's, who they feel most comfort with, or where they've received support in the past. And so we're doing a lot of crisis support in our settings. A lot of adjunct group interventions. This can be particularly powerful for communities we work with to heal in community. So really being flexible with offering groups for a variety of conditions. And then also just thinking about things in an intergenerational and lifetime course way. So because we are in the folks' medical homes, and we've been around for a while, so we tend to see families intergenerationally. So not uncommon, where we might be in a clinic with several clinicians, and one seeing a grandparent, one is seeing the parent, another seeing a child, and it's just, I think, a beautiful part of a practice that's grounded in the medical home, that we can be of service to the family in these ways. So thinking about it, the long view as well. So who is on our team? And again, we're centering the patient at the middle of our team. And also just there's many spokes. And again, like this can change and shift depending on the clinic that you're in and the resources that you have. But generally speaking, this is kind of who is on our team. And I do want to point out, we have, our traditional members, right? We've got, our physicians, our nurses, our medical assistants. And then we have some folks, these might be new players, integrated behavioral health medical assistants. These are folks who are particularly supporting the integrated behavioral health clinicians. But I also want to kind of highlight a couple of roles here too. So we very much have case managers on our team, and these are folks who are really addressing social determinants of care, of health, excuse me, and they're really helping our folks in navigating access to all the vital resources that oftentimes are first and foremost, even before managing any behavioral health concerns. And also want to highlight the front desk and give them a moment here too, because our front desk is absolutely part of our care team. I was just in a meeting the other day around developing some policies and protocols around intimate partner violence screening. And it was a really beautiful moment where we're having a team-based meeting, and the one of the front desk members spoke up and said, well, I feel like this is my role because I see a lot of what happens in the waiting room. And I'm also, able to flag, any concerns for the medical provider or the clinician who's seeing the individual on that day. So just a really beautiful example of how, everyone has a role to play, in providing this quality care. So that is who's on the team. Bit more of how things work on the ground, and we're going to dip into screening in a second. But universal screening is definitely a part of integrated practice. The warm handoff, some of you might be familiar with this. I also heard another clinic calls it warm connections, which is kind of nice. But bridging from medical to behavioral health, and we'll talk about that in a second. Assessment. So we are doing, even though we're not opening cases formally as we would in more of a specialty setting, we're absolutely doing full assessments with folks. So our biopsychosocial spiritual assessments, whole person assessments. There's evidence, again, as I mentioned before, evidence-informed treatment. So we're taking our evidence-based practices and allowing that to inform the work that we do. Shared medical records, and that this is something that's kind of evolving and growing as we go along. But we have an electronic health record that we share. So we're clinicians are documenting in with medical providers, with our medical assistants, everyone's sharing and has view into those medical records, including our patients. And so we have very open systems for documentation. And again, I mentioned the population-based care. So universal screening, this is again, a hallmark of integrated care. And we really think about screening as, being able to detect, who in our population might need some services, but hasn't really come forward and asked for them. And also thinking about like prevention, so catching folks on the early end of any behavioral health concerns. And really as an intervention in and of themselves. So I love talking about the importance of screening as also just like signaling like, hey, we care about these things here too. So, you go to your medical provider, they're always going to take your blood pressure. So to me, that signals, blood pressure is important in this space, right? And so then at the same time, if we're screening for depression, or if we're screening for relationship safety, that's also a cue to me that, oh, this is also important in this space. So I love how it does that kind of, passive messaging that this is also part of your wellness and your care here. So so it also helps us triage needs. So we can look at those scores on screening and say, this person, might need to be seen more urgently than someone else. And then we can track symptoms and progress over time using screening as well. And it is a practice standard, so understood by all providers in our setting. It's a kind of part of the language that we speak, and can also serve as a psychoed tool for patients. So, for example, if a patient fills out a screener for depression, we can use that very screener and just say, oh, these things that you were saying yes to, these are all kind of falling under the umbrella of depression. So let's take a moment to talk about this, the symptoms and what you're experiencing. And also, I just want to, as amazing as screening is, and as much as we use it in our day in and day out, I do also want to kind of pause here and say that screening is not for everyone. And so we've seen in our practice many times that there are certain patients for whom screening just isn't as relevant. So it could be maybe there's literacy issues. It could be that the concept of screening just isn't something that people feel comfortable with. So really emphasizing that having some flexibility around our screening is really important. So I often talk about this. I put the clipboard there because I'll often say when I'm training medical assistants around standardized screening, I'll say, sometimes you just have to put the clipboard down because it's not going to work for this patient, and that is okay, right? So just thinking about that as well, we learn a lot from our patients, as I mentioned before, and I've even had patients say, I don't want to talk about those symptoms, or I don't want to, fill this out because, in my culture, the more I talk about the negativity, the more I'm bringing that to myself. So again, a great example of, in those cases, just, how do we kind of take a different approach? And just to kind of dive into screening a little bit, this is where we get into the alphabet soup of so many acronyms. So these will be on the slides, and you can access these afterwards as well. But I do think it's important just to kind of talk about the different types of screening that we do in primary care, because there's a lot. So federal guidelines, there are federal guidelines around depression and substance use screening. So those, in our practice, every patient that comes in is going to be screened for those two conditions at least once a year. So for depression in adults, we're using the Patient Health Questionnaire, PHQ-9. And there's an adolescent-friendly version that's just a little rewording of a couple of things. And one thing to note is in primary care, we're really prioritizing screenings that are brief enough to be able to use effectively in practice, and are pretty straightforward. So, it's really just to kind of get a little bit of a, little hint of like, is there something going on here that we should dig into a little bit deeper? And then for substance use, there's a variety of screeners. We tend to use a couple questions around substance use on the front end. And then if those are positive, we'll move into age appropriate assessment tools like UNCOPE. And then for adolescents, there's what's called the CRAFT 2.0, and also has a new version that talks about vaping as well. And then these are additional assessment, screening and assessment tools that we use as well. So if we do some trauma screening in some of our spaces. So we use the PC-PTSD, we'll do ACEs screening. And then we also have used an adapted screener for folks whose maybe first language is an Indigenous language, and where screening for somatic symptoms is a little bit more helpful. So we use this what's called a Maya toolkit screener. I have a link in the resources at the end, just to kind of get more at somatic expressions of trauma and depression. So that's also there. Some anxiety screening with GAD-7, relationship safety, as I mentioned before, which is called the HITS, and some additional question screenings that we just add in ad hoc. So at some of our clinics, we want to screen around newcomer access, panic, and psychosis. And our screening flow is generally it's really happening on the medical side. So our medical assistants are administering the screening, and then they're inputting the results into the electronic health record. And they're usually flagging for our medical providers if anything's positive, or especially anything urgent. And then the medical provider kind of comes in and then reviews the screening with the patient. And if appropriate, they might offer referral to behavioral health at that time. And we talked a bit about the warm handoff or warm introduction, but we really like to think about this as an extension of a relationship. So, thinking about patients who come in to see their primary care provider, sometimes over the span of decades. So they have a lot of built up trust with that provider. Might also be that multiple family members over generations are seeing this provider. So they've been a part of their family for a really long time. And so the warm handoff is really, how do we extend that relationship that the provider has with the patient or family to now the behavioral health side, to kind of smooth that transition into receiving behavioral health care. And it really, thinking about this as destigmatizing accessing behavioral health. And we always really want to emphasize autonomy and choice in these transitions. So, it's absolutely 100% always patient choice. And, in best case scenario, you're introducing the service and having patients opt in to these services. No, I won't go over this, but I did just, want to kind of also flag that we are doing these full biopsychosocial assessments, spiritual, cultural assessments when folks are landing on in our spaces, and really pulling for like multi-factors that are impacting the clinical picture. These are some of the evidence-informed treatment modalities that we utilize, which I think many of these will be familiar to you all. And then at the bottom, I definitely put in that we're often using cultural adaptations to a lot of these tools. So, and we've had the great fortune of having our team be able to be receive training, oftentimes in Spanish for a lot of these modalities, which has been really wonderful to kind of think about how do we not just translate concepts, but really adapt concepts to best fit population. Okay. So I'm going to take a few minutes to talk a little bit more about the culturally responsive context that we're working in and what we try to do to bridge some of the gaps here between really working, we are working in a medical setting, it's a very westernized setting. And so how can we kind of bridge some connections for our patients who may have not received care, in this way previously or in their home countries? So really thinking about in the center, we're bringing to bear, definitely using a lot of research-backed interventions. We're looking at our clinical practice, and then also really emphasizing our knowledge of the community. So that might be lived experiences from our staff, also might be experiences of working alongside the community for years. But we're also really bringing in what is the social and cultural context that we're working within. So socially, we're thinking about, what's kind of like what's the water we're swimming in, right? So social determinants of health, what are access to resources, what level of access to resources do our patients have? We're all living in a post-pandemic landscape, so not uncommon that we won't sit to think about, oh, I'm working with this 14-year-old and having a lot of issues with social anxiety. Well, how old were they during the pandemic? Okay, let's count backwards. And so really thinking about how that impacts the symptom picture. And immigration policies are hugely important. What's happening right now, in terms of the policies, how's that impacting our care and our patients' ability and openness to accessing resources? And really thinking mightily about community resiliency factors. So what resiliency factors are already existing in this community and how can we bring some of those into the clinical space, right? And then in the cultural context, again, so many different concepts of what healing looks like. So how can we kind of bring some of those into the rooms? We'll often have conversations with patients about what other ancillary supports are you using? Are you seeing a community healer? Are there other practices that you bring in to sustain your wellness? Again, cultural resiliency factors, thinking about how stigma is impacting the picture, and the individual's immigration status and how that might be impacting access to different services and even openness to access services. And I also put at the bottom, we're often working with high percentage of unaccompanied minor populations, and that can also impact the cultural context. And always just want to, think about and interrogate really like what is the lens that we're using at any one moment in time. And so again, we're very much in a medical model, and we can't we need to kind of be real about that. And I think, medical models are often based on kind of more an illness-based approach. And, we're often working with individuals who are coming from more indigenous healing backgrounds and which are based more on wellness. So how do we have conversations about that in our work? How do we talk about trauma, right? Intergenerational trauma, multi-generational trauma. And also just awareness of how oftentimes there can be misdiagnoses because of exposure to trauma. So thinking about that, breaking that down, we'll often be thinking about a differential diagnosis and saying, how is maybe trauma showing up here and clouding the picture or shifting the picture a little bit. Again, focusing on strengths, resilience, really bringing in full person assessment. So what are all the different vantage points for this individual and how can we bring those into the space? So cultural, spiritual, somatics, cultural adaptations. Again, I mentioned this a little bit before, but how do we let that evidence inform our treatment, not take it over, but really inform it? And then I always, in supervision particularly, I'll have a clinician who's really struggling with a diagnosis, like, is it this or is it that, and I'll almost say, like, diagnosis is something, but really, like, what are you saying about what you're seeing and what the patient is sharing with you, right? What's that clinical summary? How are we bringing all these factors together? And how are we really thinking through all the different dynamics? So diagnosis, it's a piece of it, but it's not the whole. Um, and just again, holding that multiple perspectives on healing and how folks heal, right? And allowing space for coexisting approaches. So, I love this. I love working with patients who, maybe they're taking an SSRI, but they're also seeing a community healer and they're also going to church. And, so they're bringing all those, and signaling that, it is absolutely okay and actually welcome to bring in all these different pieces of ourselves into treatment so that we can best understand how folks heal, right? Um, and so this is a real zoom in, but if helpful to anyone, I always do like to offer up, like, here's some open questions that we use in practice often that really, I think, dig for some of this information and help round out our clinical picture when working with folks. So always like to ask about, how does your, partner, family, child think about what's happening? How is depression or anxiety trauma viewed by your family and our community? If you were back in your home country, for example, how would you manage these feelings there, right? What would what things would you do? Who would you seek help from? What does it mean to use, and then, whatever symptom we're using in your family and community, and or what does it mean to you? What are you most proud of, and what do you think you do well? And again, like, strength space. And then I love this. It's like, what do you think is happening, right? We're practicing in a context where there are a lot of experts, but often I think the most powerful thing can be turning it back to the patient and asking what they actually think is happening. There's a lot of that wisdom in the room. Um, so I have a patient scenario, but I am worried about time. So I'm going to offer this. I'm going to kind of just read the case because it's a very common kind of situation, and maybe just folks can kind of be thinking about the cultural and social factors of this case. Without going too deep into this during our time, because I do want to open up some time for questions. I think I never know, like, how information's landing, so I want to make sure folks have a chance to ask some clarifying questions around the conversation out. So I'll just read through this real quick. Alex identifies as a 16-year-old cisgender Guatemalan male who recently arrived to the United States from his home country. He crossed the border on his own and reunited with his biological father, who he has not seen for 5 years, and is now living with him and his wife and children. Alex had to leave his home country due to community violence and threats to his safety. He's establishing care at a primary care clinic today, as he needs immunizations to complete his school registration. So this is, here's someone who, this is in a school-based health center. They need immunizations, right, to go to school. That's why they're coming in, not about any of these other things, right? And then just to see how this works, so as he's roomed for his medical visit, the medical assistant provides him with a screen for depression, substance use, and trauma. And, he scores high on depression and trauma screeners. And then so the medical assistant alerts the primary care provider that those screens are positive. So the medical assistant, says what they say to introduce the screen. Medical provider comes in and then does the pitch to behavioral health. And so I just kind of offered some language here. So, I work closely with, Jane, who is part of our team. Alex and I have been discussing this. We're hoping you can help with this. So really just non-stigmatizing, really accessible language, and bridging all those things together. So in an ideal situation, if Alex agrees to that intervention, then he'll meet with the clinician, and then the clinician will do a full assessment, talk to Alex about some options for treatment, and then loop back with the primary care provider and kind of close that loop. So again, we won't have time today, but I do want to just kind of offer up this context of thinking about, like what in this particular case, what are some cultural factors that we might want to keep in mind? What are some surrounding social factors that we also want to keep in mind as we're thinking about ways that we're going to be of service to Alex in treatment? And I'm going to pause there. We'll be back over here because I would love to just open it up, talk at you all and myself for a very long time. So I just want to take questions here.
Thank you so much for everything that you shared. I mean, the broad intro to integrated behavioral health, and then the way you just brought it home with this case of to see what that can look like in practice. We do have several questions coming rolling in, so I'll kick off with the first one. So this goes back to early on. You were talking about how we really focus this integrated behavioral health on mild to moderate situations. And so one of the first questions was, can you please speak about why severe and specialty behavioral care can't be integrated into IBH?
Oh yeah, it absolutely can be. So yeah, and I should say, basically we are seeing everyone in primary care because everyone comes to primary care. So there's no like, we can't meet with, someone who's having a crisis today, right? It's really about who we're aiming at providing a course of treatment to. So we will see folks absolutely in crisis, even for check-ins. And it's a very common thing where folks maybe are presenting with a need for a higher level, like maybe they really, need to be assessed for psychotropic medication or more like, weekly therapy, intensive care, and they're just not ready to do that, right? And so we do tend to continue to see folks in primary care. And so what conversations we'll be having with them is that, wow, like it seems like you're really struggling right now. There's a lot going on. You also want to explore, maybe medications. And typically, because of all these things, you would qualify for much more frequent care than we can provide in-house. Would you be willing to, access that care? And then we kind of like talk about barriers to that care and get folks there. But not to say that we wouldn't provide that care in-house. But generally, integrated care, we're seeing folks usually every sometimes 2 to 3 weeks apart. And also for briefer courses of treatment, like 8 to 10 sessions. So if we hit upon someone who, we're seeing what the mental health condition they're presenting with really warrants weekly therapy, more wraparound services, we absolutely want, patients to get the care that they need and deserve. So we're going to shift our efforts to helping them step up to that care. But yeah, but we see everyone in this for sure.
Gotcha. Thanks for that. I'll do one more, and then Julie, if you have a question you want to bring in. So you talked about adapting evidence-based modalities, bringing those in, cultural adaptations. And so one of the questions comes in is, do you have any resources or those things? And I was also wondering, you talked about how you're doing this and you've gotten all these training. Is there one culturally adapted that you have found to be particularly useful, or one that you kind of keep coming back to? One example of those things that you could share. So resources or examples of what that has looked like.
Oh yeah. So yeah, resources in the community. There's all kinds of folks who are doing such exciting work. I mean, I'd be remiss if I mentioned just like one or two, but lots of folks who, and I kind of, what we look for internally, if we're going to do a training for our staff, is we're looking for folks from the community who are, in our case, offering trainings in Spanish, because it's, there's amazing work. There's amazing trainers who can do this work and training in the language that we're actually providing services in. So that's best practice, right? If we don't have to then go translate and change things around and culturally more, relevant, because we're going to be seeing similar populations. So it'll land, kind of, it'd just be more relevant. So we usually strive towards that in terms of community resources. And I can give a specific example when I was facilitating these trauma groups in the schools, or CVIDs, groups that we were doing in the schools. And we started doing a couple groups in Spanish for unaccompanied minors. And it's a very CBT focused curriculum, amazing curriculum, great outcomes, love it. We've been using it for years. And as we started kind of doing everything in Spanish and with recent unaccompanied immigrants, we started to see that like things like the CBT triangle weren't really translating well. And so one example of that is needing to label the emotion. So thoughts, emotions, behaviors, right? And so when we would get to the thought, people could really relate to, here's the thought that I'm having. When we started talking about emotions, we saw this divide happening in the room, and what it was about is a lot of times, there was much more leaning towards expression of somatics versus
Mm.
labeling. So, for example, instead of saying I feel anxious, it was like my stomach would start hurting, my heart would start beating really rapidly. I'd sweat, and so we had I remember this distinctly in the room, we had one student saying, you're anxious. Another student was like, no, 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 my stomach's hurting and I have a headache. And so learning to just sidestep that completely and say, you know what, we don't have to label. We can just talk about like, how am I experiencing this in my body? So a lot of times it's not negating a modality or really changing it. It's just setting aside a piece of it because it's just not fitting or it's not landing. And so,
Mhm.
but that takes a lot of really like, you're really looking for that feedback from the patient that you're working with, and you're kind of co-creating in that moment, if that makes sense. So I'm not letting go of CBT because it's great and I love it, and I really think it works very effectively. But there are certain pieces of it that if it's not landing, I might just kind of put it aside for the moment. So that's one quick example.
That's awesome. I feel like that was such a good example of what you said of like, we integrate this in, but it doesn't replace the treatment. So you're really relying on your own knowledge and wisdom to bring that in and make it work. So I'll turn it over to Julie now to ask the next.
Yeah, thank you so much. This has just been a great webinar. I have a question from someone who's actually working in an IBH setting already and is talking about, the doctors, the primary care physicians having to deal with so many issues in such short visits and not having enough time to do or review the mental health screening. And they're wondering if you have any thoughts or tips on how to support these medical providers to be able to address mental health in such short visits.
Yeah, yeah. So many thoughts. We could talk about this for so long. But one thing I will say, I mean, I think the thing that most immediately comes to mind for me is, you know, really thinking about that feedback loop to medical providers. So meaning, medical provider, they're maybe identifying, oh, I think there's depression and there's something going on. Please see this patient. And then taking the time to really loop back with that provider and like complete the sentence, right? Yes, that patient that you sent to me, this is what's happening. This is what we're doing. And then I'm seeing them get better. What do you think? And the reason for that is that, like, definitely there's so many competing needs in 15 minutes. It's like this impossible thing that we ask our providers to do, right? But what I have seen in my practice and working with providers, and the amazing thing is at La Clinica, we've had integration for enough time that providers really do utilize us and understand what the work is. That when you're giving that feedback loop, the provider is then seeing like, oh, right, this totally makes sense. This is totally worth the time, right? And so I've had providers who will say, that really long screener that has like depression screen, anxiety screen, trauma screen. I'm starting to use that a lot more in my practice. When, a year ago, a provider been like, what? No, we're not going to do more screening. We have no time for that. So it's about like, what is the value? Like, is there a benefit? And having these team-based conversations where everyone's seeing the benefit, we all then have the buy-in. Like there's no sales that we got to do because everyone sees that there's a benefit, right? And patients will even say the same to the provider, like, I'm so glad you asked about that, right? Like, I know I can come here because you all want to know about all these facets of my life. So, yeah, that's the thing that immediately comes to mind. But yeah, but I mean, we need longer visits too, right? Like, let's fight for that too. So,
Yeah, no, I appreciate you talking about it, within the context of the structure that's really tough. But it sounds like follow-up and persistence and looping back in to the provider and keeping that thought process going about these screenings and what they mean and the impact. So I really appreciate that. We have other great questions, and I know it's 10:59. Tiffany, what do you think? Do we have another minute?
Well, maybe we could do that last one seems
Yeah.
like it could be quick because it's a yes,
Yeah.
no. And so,
Yeah.
but Rosa said, I really appreciate your model of integrating medical and mental health care. Has there ever been a time that you integrated a family identified healer or non-traditional practitioner into provider meetings and such?
Oh yeah. Oh, and this is where I'm like, oh, I should have done a shout out. Within La Clinica, we have this amazing program, Cultura de Bienestar, that actually, so it's in Alameda County primarily, little touches in the outer counties as well. But basically, what it is it's a prevention model. And it absolutely is a collaborative model where they bring in Indigenous healers to do like groups and community-based events that are focused on wellness and healing. And so we absolutely, like, we refer to them, they refer back to us. And so they're very much a part of the model, which is a huge benefit that we have. But apart and separate from that, yeah, we have definitely, I mean, I think I talk a lot more about like bringing them in the room, like more in a conversation based, like, it is okay to talk about, and we all know that, in addition to coming here, you might be going other places. But when I think about incorporating into care, I think about Cultura de Bienestar and the great prevention work that they're doing. And so we'll often like have their flyers up and be like, oh, there's a community healing event happening this weekend if you'd like to participate. And so again, I think a lot about how are we also passively communicating to folks that this is important too. So having those things in our spaces to signal that, like, yeah, we understand that, like, there's many ways to heal, and so we're supportive of that too.
Awesome. Well, we want to respect your time and everyone else's time here. Thank you again so much for everything that you shared. It was wonderful. Really appreciate it and all the work you're doing at La Clinica and for supporting our community. So thanks again, everyone. Like we said, the slides will be up on our website. If you want to know exactly when that happens, easiest way is to subscribe to our IBH YouTube channel because you'll get a notification. Otherwise, just go back and check it. It takes about a week to get everything up there, the recording and the slides. We really appreciate you, Erica. This has been wonderful. Have a wonderful rest of your day. Everyone have a great weekend. Take good care.
Thank you. Take
Thank you,
care.
Erica. Thanks, everyone.